Hi everybody, and welcome to our module on pathologic calcification. Pathologic calcification is the abnormal deposition of calcium in tissues. Calcium is normally found in our bones, but when calcium starts to deposit in the heart or the liver or the pancreas, this is called pathologic calcification. This occurs in two flavors. One is called dystrophic calcification. This is a local process that affects isolated parts of the body. The second type of pathologic calcification is called metastatic calcification. This is a systemic process that affects diffuse parts of the body in multiple different tissue beds. We'll start by talking about dystrophic calcification. This is the result of necrosis. It occurs in diseased tissues that have undergone necrosis. Some examples are atherosclerotic vessel lesions. So if you go into the anatomy lab and your cadaver is from a patient who had some atherosclerosis, if you feel those vessels, they will be crunchy. And the reason they're crunchy is because there is calcium in the walls of the vessel from atherosclerosis. This is an image here of a carotid artery taken from a patient with carotid artery stenosis. It's got this white plaque lining it, and that is evidence of dystrophic calcification. If you could feel this artery, you would feel that it is very hard and crunchy from calcium. Damaged heart valves can develop calcification, and this can lead to stenotic lesions. Lung nodules can develop calcification, and there are many, many other examples. Sometimes when you see calcification, it's not causing any trouble whatsoever. It's just a sign that there was previously necrosis in this region. In other cases, the calcification can cause disease. The classic example of this is aortic stenosis. In aortic stenosis, the aortic valve becomes damaged and calcium deposits on the valve. This makes the valve thick and difficult to open, and that leads to aortic stenosis caused by the dystrophic calcification and thickening of the valve. On standard H&E staining, dystrophic calcification just looks like purple deposits. That's what calcium looks like, and this is an example of it shown on the screen here. In the next few slides, I'll go through a couple of clinical examples of dystrophic calcification. One of them is chronic pancreatitis. The classic finding on CT scan is a calcified pancreas. This is a picture of one on the screen here. And the reason there is calcium in this pancreas is because this patient has had chronic inflammation of the pancreas. That has led to necrosis, and necrosis leads to dystrophic calcification. Another example of dystrophic calcification is psammoma bodies. These are calcifications with a layered pattern. They're sometimes said to look like an onion. This is an example of one on the screen here. You can see psammoma bodies in some neoplasms, for example, in cancer of the thyroid. And finally, this is a CAT scan image of a patient's heart. This is the left atrium here. This is the aorta over here. This is the left ventricle right here. And these white things here are the coronary arteries. So this patient has coronary artery disease, which involves chronic inflammation, and that can lead to dystrophic calcification. And this is the basis for using coronary CAT scans to identify calcium and make the diagnosis of coronary disease. Dystrophic calcification is entirely the result of necrosis. It has nothing to do with elevated calcium levels in the serum. Serum calcium levels are normal in patients who have dystrophic calcification. It's believed to be caused by damage to phospholipid membranes in cells. When this happens, calcium can bind the phospholipids, and then there are enzymes in the cell that add phosphate to the calcium, and this basically is a process similar to the deposition of calcium phosphate in hydroxyapatite in bone. Basically, miniature bone tissue is being formed in areas where there was prior necrosis. This generates microcrystals of calcium and phosphate, and the crystals propagate and grow, and that leads to calcification like we saw in the last few slides. Dystrophic calcification is relatively common. You can see it in coronary disease, pancreatitis, and many other conditions. In contrast, metastatic calcification, the other type of pathological calcification, is relatively rare. This is seen only in patients who have hypercalcemia and or hyperphosphatemia. What happens is the calcium and or phosphate levels get so high that calcium and phosphate bind together and deposit in normal tissues. So in contrast to dystrophic calcification, this form of calcification can be seen in normal tissues. It mostly occurs in tissues that secrete acid. The reason for this is that these tissue beds have a high pH internally because they are secreting acid, and this favors the deposition of calcium and phosphate. So classic locations for metastatic calcification are the GI mucosa and the kidneys, and as you know, cells in these tissues often secrete acid. Other areas are not so obvious and are not so related to acid secretion, but these include the lungs, the arteries, and the pulmonary veins. Shown on this slide is a biopsy from the lungs in a patient with metastatic calcification. You can see this dark material lining the alveoli. That is evidence of metastatic calcification. I'll finish this video by going through some clinical examples of metastatic calcification. The first one is calciphylaxis. This is something that is seen in patients with chronic kidney disease, especially patients on dialysis who have hyperphosphatemia. In the renal section, I talk about how patients with chronic kidney disease often develop an increased level of serum phosphate. When this happens, the phosphate can be taken up by vascular smooth muscle cells, and essentially bone formation or osteogenesis can occur inside of smooth muscle. This will calcify the vascular wall, and this has a couple of clinical consequences. First of all, the systolic blood pressure will go up. In the cardiology section, I talk about how stiff vessels tend to produce a higher systolic pressure than flexible vessels, and patients with chronic kidney disease often have hypertension for many reasons, and this is one of them. In addition, small vessels with calciphylaxis can develop thrombosis, and this can lead to the formation of painful nodules and skin necrosis. This is a picture of a skin lesion in someone who has calciphylaxis, and this is another one of the consequences of this form of metastatic calcification. Another clinical example is nephrocalcinosis, and as the name implies, this condition involves calcium deposition in the tubules of the kidneys. This is caused by high urinary excretion of calcium and phosphate, which favors the deposition of calcium in cells of the kidney tubules. This is seen in patients who have hypercalcemia and hyperphosphatemia, for example, patients with hyperparathyroidism or sarcoidosis. Most of these patients will also have kidney stones because anytime you have lots of calcium and phosphate in the urine, that leads to kidney stones. But in addition to kidney stones, these patients can develop nephrocalcinosis. This is an X-ray from a patient with nephrocalcinosis. This is the right kidney here. This is the left kidney over here. And you can see that inside the kidneys there are white fluffy areas. That is caused by calcium deposition. This is an example of metastatic calcification. It's also an example of nephrocalcinosis. In most cases, nephrocalcinosis is asymptomatic. It's often identified on routine imaging of a patient with a history of hypercalcemia or hyperphosphatemia. It can, however, in some cases cause polyuria and polydipsia, and it's high yield to understand this because this is a tie-in with renal physiology. Shown at the bottom of the screen is a drawing from the renal physiology videos of one of the principal cells in the collecting duct. These cells absorb water from the lumen of the nephron, in other words, from the urine through aquaporin channels, and they bring water into the interstitium or blood. When these cells are damaged by nephrocalcinosis, this leads to a form of nephrogenic diabetes insipidus. Basically, the kidneys cannot concentrate the urine because these cells aren't reabsorbing water. Therefore, when they can't reabsorb water normally, there's more urine produced, and this leads to polyuria. This volume depletes the patient and makes them thirsty, and that leads to polydipsia. So in rare cases, nephrocalcinosis can lead to these symptoms, a variant of nephrogenic diabetes insipidus. And that concludes our video on pathologic calcification.